So I feel like I understand things a little better if I know the reason behind why we're doing it. I feel like these verses were real bad about just doing things because what we're supposed to do. You know, we get this med because we're told to get that med. So I'm going to kind of explain everything. An image might be a little over your head, and that's perfectly fine. But I'll try to tie everything together with why we're doing the treatments for it that we are. So what image is? So in the basic normal human body, normal physiology, when calcium enters a cell, it binds to the ryanodine receptor on the sarcoplasmic reticulum within that cell. And that allows calcium to enter the cell, and when calcium enters the cell, it allows more calcium to be released so your body can contract with acting mindset. Well, and then in order for that calcium to go away, for that contraction to stop, when you contract your arm, you want to be able to let it loose again. In order for that to happen, the body, through the circuit 2 pump, with the use of ATP, which is an energy-dependent process, and that plays a big role in the things you see, tries to pump that calcium back into the sarcoplasmic reticulum. So, in malignant hyperthermia, it's an inherited trait disorder where they have a defect of the ryanodine receptor. And it basically allows all this calcium to come in, and when it binds that ryanodine receptor, it just stays open. So calcium rushes into that sarcoplasmic reticulum, allows more calcium to come out, and it's just a vicious cycle that just keeps continuing and continuing and continuing. To kind of think of it like if you had a pitcher of water with a hole in it, you keep filling it up, and the water just going to keep running out. And for you to fill that bucket takes energy, and it just keeps depleting. You're never going to fill that bucket up. So it's kind of what happens. So the things we see when this happens. Does anyone know the first thing we're going to see? Most likely. One of them, most likely. Rising CO2 is probably the first thing we'll see. And if you think about it when you exercise, so when you're exercising, you start breathing very heavy, your heart rate gets up, and it's because your body's making a bunch of CO2 because you're using energy to work out. So when this happens and all this calcium and all this contraction continues, you produce a lot of CO2. And when that happens, first thing you're going to see is CO2 because we get rid of it through the lungs. So we'll see that up here. High CO2 is probably the first thing. High heart rate, someone said that, you're going to see that too. Same thing, your body's depleted of oxygen. It needs oxygen to make ATP. So it's going to pump oxygen more and more and more so the heart rate goes up to increase your cardiac output. Other than that, what someone say? Muscle rigidity, yes. Masseter spasm is very common. So your jaw will be clenched up like this, and you'll feel that. You can't move your jaw. There's actually been cases of like when someone has this happen post-op, like they can't get their jaw open to get tubing because they're clenched down. So that can happen as well. Anything else? Temperature is one of the later things you see. I mean, you definitely see it, but it's one of the later symptoms. So when that's happening, you got a serious problem. So other things you're going to see. Anything else? Okay, so
the heart rate go up.
Yeah, tachycardia. Yeah.
Okay, and then blood pressure and
Blood pressure will be labile.
Okay.
So another thing that happens, if you CO2 and acidosis go together. So if you have a high CO2 in the body, your body is acidotic because CO2, the way it breaks down the body, you get an acid like byproduct of it. So your body gets acidotic. So you get acidosis, metabolic acidosis. You'll see hyperkalemia, and a lot of times kidney injury will be a later sign, but you'll see some severe kidney injury. And the reason that happens is because when this hypermetabolism within the cells, you think of like when you do work out, if you ever have, like your legs are so sore the next day, well, you broke a lot of cells when that happened. But when you break those cells, all of its contents get released. And the main electrolyte inside of the cell fluid is potassium. So when all that potassium comes out, you see some nasty hyperkalemia. And then the hyperkalemia is what could cause cardiac arrest if that happens, or ventricular arrhythmia or something like that, VTAC, VFib. It's from hyperkalemia. Also, a bunch of proteins within the cell. When the proteins get released, you see those are damaging to the kidneys. That's why you get kidney failure as well. Anything else? I don't think there's some other things you'll see on here. You can get like DIC, Other than that, you get cold colored urine. That's from just all the myoglobin, those proteins I was talking about. Other than that, you see a high, breathing pattern if we're not, paralyzed or anything. You see a high increase in respirations. That's just trying to get rid of that CO2. So, does anyone know what the first thing is? So when this happens, let's say we're in the case, and this happens, what's the first thing we're doing? Shut off the gas. So, does anyone here know the triggering agents for MH? Succinylcholine. And because it causes our body to basically, it causes a muscle contraction that just stays open. So it's just going to worsen our problem. And all the gases. Except that we actually use. Nitrous. Nitrous is safe to use. So, you see your anesthesia provider using nitrous on these cases, it's perfectly fine. It's the desflurane, sevoflurane, isoflurane, I think is the one we have here. So, yes, stop the triggering agent, 100% oxygen to the patient, and we need to get the charcoal filters. Those can be found in the anesthesia workroom. Well, is there some in there?
I think there's one in there.
But, if we don't have this in the anesthesia workroom right next to the fixes, they're down here lower left, they're sitting right there. 2 little orange filters. We'll pop those on. That way we can, because even though we're putting 100% O2, there's still gas that's kind of lingering in there, and we want to stop that. All right, what's the next thing we're going to do? Yes, that should be one of the first things. We're stopping the triggering agent. Someone needs to get on that phone and call the MH hotline because those guys are professionals. Where this happens like 1 in 100,000 cases you'll see this. So very rare. So yeah, we don't know what we're doing pretty much. So just call that MH hotline and they can help us out. And what's next? Yeah, that's the only thing that's going to treat this. We can do all these supportive treatments to fix the problems we have at hand, but Ryandex is the only treatment we have. Dantrolene, Ryandex, I think we just carry Ryandex. Funny enough, Ryandex, the Ryandex or something, so I always thought that. All right, what else are we going to do? Okay, yep, cool patient, ice in the armpits, groin. Us giving 100% O2 works well. So that 15 liters kind of helps blow off some heat from there as well. Cold fluids, intravenous cold fluids, get them out of the fridge and the anesthesia workroom as well. And do Foley washout and that too.
We used to have some fluids that were frozen. Do we still have those?
Yes. It's in the freezer in the anesthesia workroom.
All right. What are we doing? What else are we doing? Get the cart. Yeah. Get the cart. As soon as someone says we have MH going on, we grab that cart and bring it in here. All right. And then when this happens, the rest of the steps we're going to do are basically things to try to treat all those side effects that I talked about. A lot of that stuff's going to be done by the anesthesia provider, but it's going to be like, hey, need sodium bicarb. Who else do we need to have up there? Pharmacy. Pharmacy needs to be up here. Especially for all these different drugs we're going to have to give. They would definitely need to be up here with that. All right. So, did I miss anything, Tina?
I think you got it all. And then we would, if it was a child, we would obviously call Children's Hospital
Yes. Yeah,
for transfer.
And just a fun fact for you. So I said 1 in 100,000 is the incidence in adults. With pediatric cases, it's 1 in 30,000. So still very rare, but it's more, and it's more common in males.
Typically, in these procedures, we would abort the procedure.
Yes, promptly tell the surgeon. That's a good point. Promptly tell the surgeon, hey, whatever you're doing, we got to close up and finish because they're not don't finish the surgery. I mean, unless it's like a life-threatening situation, vascular case or something, something like that. Just close them up and do it later. I do have this here. If you guys want to look at it.
I'm going to send that out in the email.
Kayla,
Education email.
Previous student here, she did this as a project, so it's more kind of the anesthesia side of things, but definitely tells you kind of the mechanism on it and the signs and symptoms you see and the percentage of times they've seen that with MH. So, like I said, the masseter spasm, the high CO2, the high temperature, tachycardia, those are the 4 that are the sad part of that is there's like 10 other things that could be going on that all resemble that. So, when we make the MH call, we have to treat it like MH. But,
And there is a family history down here that has it, because Dr. Graham you work with Dr. Graham, your odds of getting it are pretty good, because we had a slew of them, I don't know, what, 15?
Yeah,
years
something
ago?
like
and
that.
it is a genetic inherited trait. So if a family member has it, a family member, like any family member in your bloodline has it, you could have it because it's an inherited trait.
Okay, Laura just said that we had a patient yesterday with a history.
Yes, family history. There was nothing in the chart indicating that either, and even by the time they left the OR, there was still no indication marking the chart. So typically they try to have those patients that are already marked as the first case of the day. That way the anesthesia machine is already cleared out, it's already blown out and ready. That was not the case for us yesterday, so it did take an extra about 40 minutes to blow out the anesthesia machine to cause a delay. So if there's a way that we can mark those, or I wasn't sure how to indicate that for the future.
Definitely needs to be someone with PhD. But just another FYI for you. So that these machines, without the charcoal filters, gas comes off 100% FiO2 with 15 liters a minute, blows out for 35 minutes as a GED recommendation. But with the charcoal filters, you've truly, after a minute and a half, the company guarantees that there's no agent coming through those charcoal filters. And those charcoal filters do get saturated every hour, especially in like an emergency situation where we first pop them on, there's still agent in there. So every hour we should replace those.
Okay. Yes, we were going to do that. So if you want to go over there and go over that. Do you know how to go? Okay. So Amy's going to go over the cart here for us.
So everyone, this is the MH cart. It is kept between the substerile room 2. It's kept between rooms 4 and 5. This is checked every single day by nursing staff who check it off. The top cart is locked just like any of our crash carts, and it has the Ryanadex in it. The most important thing to know is that this cart has got to be in the OR before we do any procedures. If we do not have this cart within the OR, the ASC, the AOSI, anywhere that you're going to be using anesthesia to do a procedure, you cannot proceed with your procedures because of the potential for an MH reaction. Our cart does not leave the OR unless it's being restocked. So if we have a patient that has an MH reaction, they go to ICU. This cart does not follow them. ICU has their own supply of MH because, as Owen has mentioned, there is a chance after an MH reaction has happened and they've been treated here and we've gotten them to ICU that they're going to have another reaction. Is it 13 hours later?
Yeah, so I think they get monitored for at least 24.
So they're going to have their own supply of Ryanadex. Pharmacy is going to stock that, but we need to get ours restocked back up here so cases continue. That being said, the hotline number is on the top of the cart. It's also, I think, in several different spots right there. The best way to do this is either to get the charge phone. We have 2 of them that will reach this entire OR. Use your cell phone, and you're going to give it to your CRNA or your ologist, who's ever in the room. Whoever's there first, and then hand it off. Use your phone, dial overhead, call for anesthesia help, call for all help. You're also going to want to get a crash cart in the room, like you already mentioned. Great education. The top of the cart also tells you your Ryanadex dosing on it, but there is a cheat sheet here that also gives you per your kilogram weight. That's why nurses, it's super important that your handoff sheet has your kilogram weight on it, not just your pound weight. If you're like me, I don't like to do math, especially in a short amount of time, so have that kilogram weight written out. But that will give you a dosing. That way, the pharmacy is not here right away. You can pull up as you need to.
Because Ryanadex, like I said, is the only thing that's going to reverse it. You need to get that in as soon as you can. And the minute you think it's MH, get Ryanadex drawn up.
And then as far as nursing, when help comes, because OR, we are great about getting lots of people in the room very, very fast. These cards have been made, as I viewed them all before. They actually have numbers on the top of them, but these are basically tasks that then you can hand out to people in the room. They have things like, hey, call the MH line, bring the crash cart in the room, call the lab and get some labs drawn. So put a secondary IUD in and get these labs drawn. Mix your Ryanadex. This should almost be like number 2. insert a Foley catheter, initiate cooling of the patient. So it's got all those things that he already alluded to, but they're written out on tasks, so you don't have to totally try to remember them. If we do have that patient, pediatric patient that gets MH and they do have to go to children's, we all have our smartphones now. The family usually can get there on their own, but there are directions that you can hand to family just in case. In addition to that, the cart has here listed out all different kinds of any supplies that you might need. So probably the charcoal filters are in here. I would assume we'll have to kind of look, but central line kits, lab kits, betadine swabs, another one of your filters that we talked about. This is for gastric lavage. I don't even know that this is necessarily indicated anymore, but it's there. Foley kits are in here, NG tubes. This has got central line kits, lab tubes. Nurses, we always try to check these when we check the cart because they're oftentimes going out of date. Lots of those. This one has any kind of stomach tubes, aseptos that they might need. I believe these are the esophageal temperature probes that they might need. Some extra saline, so we're checking these for dates as well. And then IV start kits, etc. So basically anything that you're going to need to know, there's some expiration dates there. But pull this in the room, this will have everything on it that you need. And most importantly, if you can't get it restocked, ask your charge nurse or someone else to help you get it restocked.
And one thing I forgot to mention too, especially like if this is like a short little case, the patient probably would have one IV, might be like a 22, it might be something little. Like we need at least a 20 gauge IV, preferably something bigger. And when we get it, we're going to draw labs off of it. Call lab, tell them we have an MH patient, but when we send labs, they need to run them quick. Because we're going to be drawing potassium. We're going to draw a bunch of stuff, basically everything, we'll shoot the whole book out. So that's just something else I forgot to mention.
Okay, so basically what's going to happen is once we get this cart in here, if Amy was the nurse, she would take that and she would hand each person that. So you would get card 1, you'd get card 2, you'd get card 3, and that's what that person would be in charge of. So if you are in charge of cooling the patient, just keep in mind that in the refrigerator in the anesthesia room is where we keep all of the cold fluid. There's stuff in the refrigerator, stuff in the freezer. That's where you would get that. Everything else you should need should be in here. That's on that card, I believe. So I was going to do like a little mock drill, but we can kind of read and see that now. So just when you have time, if you've not looked at this cart, make sure you take the time to read those cards, look at the numbers, get familiar with what's in here. And that's it. Any questions? Amanda?
I'll get that off. So back in the day, we used the dantrolene, and I know at one point that was on back order, and they had to get it back in. Do you want to explain how you have to mix it and all that, and it takes...
Yeah, so dantrolene, there's 20 milligrams per vial. So, and you have to reconstitute it with 60 mLs of sterile water. And that's another thing too. Not saline, it's water to mix with this. Because, typically, especially up here, for us, we mix everything with saline. So make sure it's sterile water that you're mixing this with. Take 60 mLs to just get 20 milligrams. So let's pretend we have a 100 kilogram patient because we get a bigger patient population out here anyway. 100 kilogram patient, and you need to give them 250 milligrams because it's 2.5 milligrams per kilogram is the ideal loading dose. So 250 divided by 20, you're talking 12 and a half vials. So take 12 and a half vials, mixing it with 60 mLs of sterile water, reconstituting and drawing it up, giving it all that 60 mLs at one time, and you can see why Ryanadex is so much better. Because the Ryanadex, it comes in 250 milligrams, so that's what we could give, the full vial, and you only can mix it with 5 cc's. So it takes a minute maybe with the Ryanadex, and it'll take extra more than 10, 15 minutes to give all that extra.
And the Ryanadex is sterile water mixture as well?
I believe.
Okay.
Yeah, 5 ml sterile water
Yeah.
for a 250 milligram vial.
Okay, great. All right, anything else?
Is there an order set in Epic for the lab?
I don't know the answer to that, but I will find that out, and then when I send the education email
So
out,
I think
I'll
on
let you
there it
know.
says something about just call lab and tell lab you're initiating MH protocol or something.
It says MH panel, but I don't know, we'd have to check for Epic if it
Yeah,
is.
I mean, we can't just send down like the.
Yeah.
Would we just put patient stickers
This,
on and send them down?
this says,
I would
inform
say yes.
lab, we will be sending blood samples down, and they will enter the MH panel orders for us.
But is that with our old system or is that with Epic, because it's been updated?
Right. I will check that out and I will send it out when I send out the education. Okay? Yeah. All right, anybody else? All right, have a good day.